Hi, everyone. This is a bit of a different talk for me. I normally have to balance the health knowledge in the room with the technology knowledge in the room. Given this is a rural connectivity summit, there's kind of a little bit of a rural angle to it. And the first thing I'll say is I grew up in Gisborne, and I didn't realise I spoke different to most of the country until I went to university in Dunedin. So that's my rural credential. My best friend is a farmer from Gisborne. He's a shepherd, runs beef and sheep. So that's kind of where I'm coming from. But I think what's most important and what I see on a regular basis, and kind of that conversation that was around Nate, Paul, I was almost tempted to just keep sitting there, because if you change farms to hospitals, cows to patients, there's a very similar story to be told about how we need to change how we deliver services in the health system as it is from an agri-tech perspective. And I made sure I took the photo of how much money you spend on innovation, because that's probably a good thing too. What I observe when I am dealing with a lot of people, because I trained as a physio originally, not in IT, and so when I'm having conversations between technology people and between health people, there's kind of a recognition that the cultures are quite different. And the observation I'd make is when the Waiho Bridge was washed away, probably 10 weeks ago now, one enterprising young fella decided that the best way to fix that was to use his dump truck to take people across the river. And that to me speaks to how the health system often operates. Someone will jump in, fix the problem without necessarily thinking about the detail or the consequences of that. You know, presumably the reason the police stopped them using the dump truck crossing the river was because it's not that safe. Conversely, when I'm talking to the technology people, the only time you'd be crossing the river would be once they'd rebuilt that bridge, and that bridge would never be destroyed again. But in the meantime, no one would be allowed to cross the river. So there's kind of this balancing act I often end up having to do. And so I think today there's lots of technology people in the room, so I'm going to spend more time on the health conversation rather than the technology conversation. Okay? What you're seeing is the number of Class 3 medical devices that have been asked to be approved by someone called the FDA in America. The FDA in America is an organization that approves whether or not we can put medical devices inside your body. So if they break, you die, or you end up horribly scarred or injured. Point being, when you look at those dots since 1960, you can see what happened when computers got introduced to the health system or into medical devices. We've gone on much more of a exponential curve in the last 10 years. In 2008, and Paul will know this, sequencing a genome was really, really expensive. Turns out in the health system even, that's going to be a lot cheaper just with the current generation of equipment that Illumina builds for health. At $100, that's less than a ticket for the All Blacks, you know. What I've got up here is a picture of a building. Does anyone know what the building is? Yeah, it's the Burj Khalifa. I heard that from someone. The corpus in health science, so how much we know about it and how much evidence we have. If you printed it out double-sided, because we're environmentally friendly, and then you stacked it all up, all of the articles that we have, because they're on average about 8 pages long, that stack of paper is higher than the Burj Khalifa. And that's how much we expect people to carry around in their heads in the health system in order to do a good job. Not only that, it grows by 2.5 million articles a year. And I read reasonably fast, but I've never met anyone that reads that fast. Not only that, and I suppose this is the most scary thing, is that in the health system, what we know we should do takes us 17 years to do routinely. So I was busy trying to find out 2002, what happened in technology in 2002. And I was one of the Napster generation. Turns out they filed for bankruptcy in 2002. And then I thought, I wonder what happened in New Zealand in 2002. Wikipedia listed the fact that we did four things in 2002 in the country. One of those things was start KiwiBank. So that's where we're operating. It's 1 year into the iPod generation. The iPhone hasn't been invented. And that's where we're practicing at the moment. Part of the reason for that is the complexity in healthcare. So it's easy to understand 9 people's stories, but it's not easy to understand 13,500 people's stories. Okay, so when you start to think about how complicated healthcare is, people turn up in a hospital with one of 13,600 things. And when you couple that with 67.5 million articles which tell you which of those things it is, you can see how healthcare starts to get complicated. And of course, that meant that we overcomplicated it. So this is an article from the New York Times last year, which recognized that the health system hates the computers we give them. So I work in IT, and I put this up, and when I'm talking to a health audience, everyone nods their head. Yeah, we hate your computers. And it feels a little bit like LIC going from a 56K modem situation to broadband, or leaving it to synchronize for 3 hours. This is the user experience we've generated for people at the moment. And of course, most of the technology we've generated comes from the US, and in part, the US and their healthcare system is most interested in claiming the most money they can rather than necessarily delivering good patient care. So in this context of technology getting away on the health system, us being really complicated and us not historically doing a very good job, it's an interesting question about why I'm standing here telling you about emerging health technologies. And I think it only gets worse when you think about the other challenges that we have. Firstly, digital is a big opportunity, but the risk is, as we've talked about, if people don't have broadband access, or they don't have access to the internet, or they don't have a phone, how can we create benefit for those people? Not only that, the more we stick on the internet, the more risky it becomes. On average, there's a hospital data set breach every week now, internationally. So it feels like a matter of time. It's been really hard for us to realize that digital dividend, so that ability to get value for money from cloud. We've been in the internet, well, been in computers for a long time. There are still some people I know in the health system who originally started in the health system programming Fortran. One of them's now the head of the iwi in Porirua. That means that our systems have never been built to either connect to the internet or be connected to each other. So when we've connected them, we've created a bit of a spaghetti junction situation. And lastly, we've got this context where all of you will own a mobile phone, all of you will do your banking online, and all of you will probably expect that you can deliver or receive healthcare services on your mobile phone. So we're kind of rapidly getting to a situation where we need to think very differently. And this is happening for the health system in general. So in health system, our health system's been designed for fixing you when you're sick, for making you better in a hospital situation, or only worrying about you when you turn up. What we're thinking about is, how do we keep you well when you're doing your daily work, daily social engagements, playing sport, things like that. We want to put the control of your health information back in your hands. So we've done a bit of work trying to understand our customers. Part of that is thinking about how many customers we have. So I'll go back to that 13,600 diagnoses. There are some broad categories, and we think about the kind of that life cycle approach. The most heavy users of healthcare are children and old people. So we've got a particular focus on trying to design the health system of the future around those people. And it turns out it's pretty easy, at least when you go and talk to clinical people or you talk to non-technical people. You start with all of those things that exist, all of those computer applications that the health system runs, and then you add all of those things that you might be doing yourself, your own genome sequence, or measuring your blood pressure at home, or the watch that you measure how many steps you're doing, or what your heart rate says. And then you just connect them all up, and you let me see whatever that information is wherever I want it. Now, it's unsurprising that that resonates so well for people. But interestingly, we're on a bit of a journey to understand how to actually do that. in reference, this is a chap that wrote that previous article. What he recognises is that health is a complex adaptive system. So from our perspective, what that means is, and I'm going to skip past some of this, is that we have to understand what our role is in the system. And so unfortunately got me today, and I work at the Ministry of Health. And the situation is such that we need to be careful about what it is we do as the Ministry of Health versus what a district health board does, what your GP does, and what you do. And from our perspective, that's about trying to understand that our job isn't necessarily in the context of horse racing to own the horses, race the horses, run the TAB and run the racetrack. We need to be careful that our job is probably only to own and run the racetrack, to make sure that other people can run horse races, to make sure that someone owns the horses, to make sure the TAB's doing a good job, or Farmac, whatever you call them, and to go from there. So from our perspective, what's most important are things like interoperability, things like architecture and standards, security, privacy and trust, a brilliant triumvirate, which means that we won't leak your information onto the internet. A set of foundation services, similar to what Paul put up, his set of APIs. Thinking about how these services and how this framework and how these enablers work in a commercial sense, because it's no good us trying to do it by ourselves. And then also thinking about innovation. So when we think about that in the context of rural, we kind of start at the bottom. And by the bottom, I don't mean the bottom of the barrel. What I mean is, from a technology perspective, we want to think about a service model as a whole. And when you think about that, the bottom of that's the network. So if we don't have network, we can't have hardware, we can't have information infrastructure, we can't do integration, we can't have applications, and we certainly can't serve any kind of customer experience. So we've been doing some work in the last month and a half with Chorus and a little bit with Internet New Zealand to think about where broadband's going. You'll no doubt be familiar with these statistics. So this is the intended coverage of UFB2, RBI2. Some outputs, what the expected outputs are likely to be. New Zealand will be in the top 5 for the OECD, a much better target than what Australia has, and some other things. So one of the conversations we've been having with education is that question of if everybody's got the internet, how can we be a part of that? And I'll come back to that in a minute, but Hotspot 2.0 has been part of our conversation. Question is, when you then apply that to the health system, what does it look like? And this is kind of pretty new, and we're not 100% sure these numbers are exactly right, but we're pretty sure they're in the right direction. It's what it looks like today. So it's a little bit small, but on the left-hand side, we've got community pharmacy. We've then got GPs, community dental, aged care providers, and the blue bar shows you what percentage have fibre at the moment. And the orange box shows you those mixed modalities, so the WISPs and the RBI and the wireless and VDSL. So at the moment, we're sitting at 74% fibre availability for health organisations, and just for kind of a context, it's about 10,000 of them. So we've got about 10,000 places that we deliver healthcare. That is what the build out looks like for the health system. So the health system is going to end up with about 97.1% coverage of fibre and about 2.7% coverage of other modalities, which is great news. What that means is we're hopefully going to have a network which is available at your health practitioner, at your local GP surgery, at community pharmacy and places like that. But that's only step one, because of course having a network, as I think it's Mike said earlier, is only part of the problem that we're solving. So once you've got a network, what the hell are you going to do with it? And can anyone access it? So the next kind of question we then asked was, what about if people don't have a cell phone? And this was kind of the received wisdom that we had, is not everybody has a mobile or a smartphone. And I'll agree with Paul here that the data's not great about what the penetration of some of this data, of some of these statistics are, or it's not that up to date. But what we know is in 2017, 94% of New Zealanders had access to the internet in some shape or form, and 71% used a smartphone. So all I can assume is that's getting better. Going back to understanding our customers a bit more, we actually asked the question, so is it having a smartphone that's the problem? And the answer was, nah, a free phone call is much better for me than it is asking me to use my data allowance. So what we're doing is we're working with the mobile operators at the moment. And while Mike was talking, I've sent an email to ask the question about what are we doing for the WISPs. We've whitelisted 6 health sites in the southern DHB area, which means that if you don't have any money on your phone, it doesn't matter. You can still access those health sites. So things like the Lowdown, things like depression.org.nz. What it means is that people that don't have money on their phone can still go online, can still use online channels. And after about 8 weeks, we're seeing a 20 to 50% growth in our web traffic for those sites. So the message is getting out there. It's quite interesting how much of a barrier using your mobile data is. And this isn't inconsistent with what we understand happened for the Ministry of Social Development when they started thinking about this as well. Point being, once we've solved the network thing, what does that let us do? Well, if you think about all of what Paul said and you think about joining up the full stack, here's a problem we've got. So we do a patient experience survey. It's kind of like a net promoter score or a customer experience survey. And when we ask the question about medicines, only half of the people that we ask the question about medicines give us a positive answer about how we explain their use. So you often get prescribed a medicine. Most people are too embarrassed to ask the doctor what it means or why they're taking it, or even to ask about the side effects. And so they feel we don't explain that well. Not only that, it's been estimated that our medicines harm, so that's where you take the wrong medicine or the wrong medicines are combined, costs the country about $220 million a year. Not only that, we only had 300 consumer completed reports of medicines harm in the last year. And when I asked for the number, they were very proud to have got 300. Lastly, there's a big number at the bottom, which is a global number, which suggests that all we know is whether you picked up the medicine from the pharmacy. We don't know whether you put it in your mouth and actually took it. Somewhere between 30 and 70% of the medicines we give out as a health system don't actually make it into the person's mouth, and that's either because they don't like it, they're bitter, or they don't know what it's doing for them. So something we've been working on, and this kind of starts to tell the story about how the health system could change, less about the fact that we're building an app, but it's designed to let you sign up directly on the phone without having to go anywhere, without having to show anyone anything, to prove who you are, and then to see what medicines you've been dispensed. Now, lots of the clinicians, when they see this, fall off their chairs because we've been trying to do this for 20 years. We started this project 20 years ago, never got anywhere. And interestingly enough, it's not so much about us building an app, come back to it's about us understanding that full stack. So from our perspective, the objectives in this space are about the need to create a reusable and secure identity. So that underpins it. This aligns to the DIA and government agendas. It lets us think about that marketplace that Paul was talking about, where we can offer APIs that other people can leverage. It tests a hypothesis that these sort of things are the right things to do to make data available, to give people access to their own data and give them some control and some knowledge about who's using their data. And the last thing is, and I think this comes back to my original comments around the difference between the health people and the technology people. The health people need something in their hand to be able to have this conversation. We've got really low digital literacy in the health system, and it makes it really hard to have this conversation about joining up the layers of the stack or to be using cloud without that. Now, interestingly enough, what we're seeing is a lot of challenges to how we currently work. So when we started this project, we costed it up on a traditional basis, and the price was about $1 million to build that app. Yeah, so we binned that idea. We're probably going to spend about $130K, and we're going to be reusing a bunch of services we already have. Not only that, we've taken an agile approach. So the original approach was to write a 150-page set of requirements before we could press go, and the alternative is taken an agile approach. Now, we've had as much pushback inside the technology space as we've ever had for any of our other projects with the rest of the business. So that's quite an interesting situation. Number two, turns out we focus a lot on patient information, so the information that exists about you as a patient, your blood pressure, your medicines. What we haven't really focused on in the health system is information for patients. So that question about what is Alanapril, what is paracetamol, and why do I care? That turns out that data is a lot dirtier than we ever thought and a lot harder to integrate into this process. Another thing we learned is that turns out we're not special and different. Lots of other technology companies and technology industries have solved this before. We're also learning that security by design is critically important. It's very hard to close a hole afterwards, but pretty easy to make sure it doesn't happen in the first place. And at this point, as I was saying before, when you show people, so the app exists. I've got it on my phone. We're getting it pen tested next week, and it goes into an alpha rollout next week as well for the country. So the alpha is going to be with Ministry of Health employees in the first instance, because the last thing we want to do is release it into the wild to 5 million people and find out we've got a problem. But we've been able to build that in 12 weeks. So for a health system which spends a lot of money on a lot of IT, it feels like we're starting to get the hang of maybe doing things a little bit differently. That's my talk.
Thank you, John. Sorry, bit of an obvious question, but what can ag learn from health? Because you were drawing the conclusions between Paul's presentation with cows and patients, and we're not talking four stomachs here.
I think the interesting thing about health is we rely on science a lot. So I showed you the picture, which was 67.5 million articles and growing all the time. I think the risk you have when you bring technology and science together is that people assume that from a technology perspective, it's all good to fail fast. I've seen a few examples in health, I think, where the fail fast methodology is fail spectacularly and fast. There's a woman who's gone to jail in the US now who supposedly invented a lab on a chip. For those that want to look her up, her name's Elizabeth Holmes, and she founded a company called TUANZ. So I suppose there's a little bit of not believing the hype, and I think the useful thing I have in clinicians, maybe you have this in farmers, and it sounds like you might, they don't necessarily rush out to the new thing, and it's hard to find those initial people, but once you've got them, we tend to leverage those people that want to try new things quite well. So we've got a really good network around those people, and we're trying to foster that. Does that help?
Yeah, we call them alpha farmers.
Alpha farmers.
Yeah, that's great.
I might steal that.
And I actually stole it from you, but now I love this concept of the digital dividend, and what I really liked is, the different perspective you brought in terms of different sectors learning from one another, because sometimes we can get really sort of a spotlight effect, a very narrow framing on trying to solve our problems, and we don't go wide enough. But I suppose that data protection one is a particular tricky one for you, because you don't really want too many people poking around seeing what you're taking, right?
Oh, entirely. So this is, as soon as you start thinking in this frame, you start to think about the data, and it's worthwhile knowing that Social Investment Agency has just done a bunch of work, which has culminated in something called DPUP, which is a data protection and use something, P for the last bit. Essentially what that does is talk about how and when you should collect data, how you should manage it effectively, and we've got into conversations around data sovereignty. So this is an interesting question of, if it lives in Australia and it's subject to Australian laws, how are we making sure it's safe for us? So, second thing is, and this is kind of the scary thing, and I'm sure you're not doing anything scary or creepy, Paul, but when you start to think about AI and machine learning, particularly in the health context, we know we need to weigh up the creepiness versus utility factor. and that doesn't feel very sophisticated, but all of you know what I mean. And if you were I was talking to one of my colleagues, and she uses Gmail in her personal life, and she came to me and she said, I think Google's spying on me. And I went, okay. And she went, I was on my Gmail, which I get for free, and then I was on the internet and I saw an ad for something related to what I was talking about in Gmail, and I went, you know, Google's an advertising company, don't you? So I think there's this acknowledgement from our end that we need to be really careful about this, and we need to avoid that creepy factor. It needs to be useful to people.
Yeah. No, well said, well said. Well, John, thank you very much for your time. Thanks for coming to see us. We can give John a round of applause for his time and effort. Thank you.